So today we're going to talk about a case having to do with a patient with gastrointestinal stromal tumor. This is a 68-year-old gentleman who initially presented with a 5-month history of early satiety and vague abdominal pain. His past medical history was notable for hypertension, for which he was taking medications and his blood pressure was well controlled. He had had a colonoscopy at the age of 55, which was unremarkable. And of note, his family history was negative for any sort of malignancy. On physical exam at the time of presentation, he had diffuse abdominal pain on palpation, but otherwise no palpable masses or any other remarkable findings. He had a clinical workup including laboratory testing, which showed a hemoglobin of 10.1 with platelets of 100. Otherwise, his laboratory studies were within normal limits, including liver function tests. He underwent an endoscopy that showed a submucosal mass measuring approximately 5 centimeters in size with evidence of ulceration. He then underwent an EUS FNA guided biopsy. On EUS, a mass with irregular borders was seen on the extraluminal surfaces of the stomach with evidence of heterogeneous echogenicity. The biopsy from that lesion was consistent with GIST and showed a high mitotic rate of more than 5 mitoses per 50 high power fields. He subsequently underwent a CAT scan that confirmed the mass measuring 5.4 centimeters at the body of the stomach, and consistent with findings on an MRI, there was also evidence of peritoneal metastases. From the biopsy, mutational analyses were performed, and he was found to have a KIT exon 11 mutation. At the time of his initial clinical workup, he was healthy, well, and had an ECOG performance status of 0. So having been found to have metastatic disease with an exon 11 mutation, he was initiated on imatinib 400 milligrams daily. He continued on that for approximately a little bit over 2 years, at which time he was complaining of some increased abdominal pain, decreased appetite. His performance status was slightly decreased, and he was found to have progressive disease. His therapy was discontinued, and he was switched to sunitinib, taken as 50 milligrams daily for 4 weeks on, 2 weeks off, and tolerated this well for approximately 9 cycles. Side effects that he noted were altered taste, occasional vomiting, and diarrhea, but again, evidence of disease progression. Then he was switched to third-line therapy, regorafenib, 160 milligrams, which he took 3 weeks on, 1 week off, and tolerated with the exception of hand-foot syndrome. He continued on therapy until his disease progressed, and then he initiated therapy with ripretinib, 150 milligrams daily orally.